Volume 5, Manual Therapy, Techniques of Biomechanical Assessment and Treatment, Advanced Examination and Treatment Techniques. This video will illustrate techniques of assessment and treatment of the pelvis, temporomandibular and costal joints, and peripheral manipulation. Each new section will be introduced by a full-screen graphic, which will be on screen long enough to act as a bookmark when speed searching through the tape. It is not necessary that the tape be viewed sequentially, and it has in fact been designed to be used as a textbook, allowing the viewer to flip from section to section. For maximum value, view this tape with course notes and a good anatomical reference book to overcome any deficit in your theoretical knowledge that might become apparent during viewing.
Hello, welcome to the lower leg. We'll be looking at the ankle and the foot in this segment. I just want to spend a couple of minutes talking about the principles of manipulation and recapitulating some of the indications for manipulating this joint, or any joint, come to that. Manipulations are high velocity, low amplitude techniques for the most part. There are a couple of exceptions to this, and for the most part they are used to basically unstick jammed joints. In the ankle, the most common jam or subluxation is an anterior or medial subluxation of the talus. And in this case, what it will do is block the conjunct lateral rotation that has to occur for you to gain full dorsiflexion. So on passive mobility testing the ankle joint, what you'll find is that the end range of dorsiflexion is missing, and there is a hard, abrupt, springy-ish sort of end feel to it. In addition, if the ankle is tested using the Taylor swing test that was demonstrated on the previous volume, you'll find that the lateral conjunct rotation is completely missing. The traction that we'll be utilizing for this will be a traction manipulation most usually, and in these cases we rely on a sudden distractive force to open the joint surfaces, and then by releasing it, allowing the normal joint tension to basically return it to its normal working position. So if we have a look at this technique, and we'll get Donna to lie down on her back, there are a couple of things that you have to concern yourself with. Come down the bed a wee bit for me, Donna. First off, make sure that the opposite leg is flexed up. This will afford some measure of protection to the lumbar spine, so that when you actually produce this fairly strong distractive force, we won't be pulling the spine into an excessively lordotic position. Hand placement for this manipulation, we'll put the ring or little finger over the neck of the talus. We have to maintain the ankle in its resting position, which will be sitting about there. We'll maintain that neutral position with the thumbs that are underneath the plantar aspect of the foot. So we have the foot in the ready position for the manipulation. The force, the manipulative force, will be parallel with the tibia and will be fairly sharp. So bringing the foot up into its resting position, everything's in place. Just feel the joint, apply a few little traction pulls on it just to feel the amount of distraction that's available to you. Don't take up all of the distraction, take up about half of it, and then your thrust is simply there. The common mistake with this manipulation, though, is that as you thrust, the ankle is dorsiflexed. If you do that, then you simply force the ankle towards its closed pack position, and you'll jam the joint even further, and the manipulation will fail. So just one more time quickly, we'll take the ankle into its resting position, maintain that resting position of the ankle with your thumbs, feel the joint play with traction, take up about half of the amount of traction there, and then thrust parallel away from the knee. This technique will work for the majority of subluxations in the ankle, whether they're anterior or posterior. However, some of them can be quite intractable and you require a more direct force. And this is the so-called J-stroke manipulation. And this will consist of both a traction manipulation and a dorsal thrust to the neck of the talus. It's important, particularly with this technique, to not increase dorsiflexion as you do so, because this is commonly done with this one, especially with this one, because instead of thrusting downwards, that occurs. So you really have to be aware of that. One way to overcome that is to use your body as the thrusting mechanism. So there's your traction force, and the dorsal thrust is applied by dropping your body down, like so. So when the two are taken together, you get this scooping movement, the J stroke. So it's this position, and then traction and drop down. Okay, once more. Traction and drop down simultaneously, like so. It's going to be unusual for you to have to use this manipulation. Generally speaking, the direct traction manipulation will be sufficient. We can also use the traction force for adhesion tearing, where we have a post-immobilizational ankle, for example, that we want to regain that last part of dorsiflexion that's being restricted by adhesions. It's important, though, before you do this manipulation, that the ankle has had a good chance of being mobilized by stretching. If these are strong adhesions, this manipulation is as likely to tear normal joint tissue as it is the adhesion. So these need a good chance of being stretched and softened. Otherwise, the manipulation is like so. Same hand position, but this time we want the ankle in its fully dorsiflexed position, as full as it can go, and we'll maintain that all of the time. This will ensure that the capsule and the ligaments are as tense as they can be. Otherwise, thrust is exactly the same. Take up all of the available traction, though, this time before you thrust, and then thrust on that tensed capsule. This is not a manipulation that needs to be done very frequently.